Good afternoon. We meet once more again. We continue with the common neonatal infections that happen. We'll talk about meningitis and encephalitis. I am your presenter, Mr. Samson. To start with, to define meningitis as the inflammation of the brain meninges, and also differentiate it from encephalitis as infection of the brain parenchyma. Also, we define meningoencephalitis as inflammation of the brain with the brain meninges. We also make a definition of aseptic meningitis as inflammation of the meninges with the sterile CCF. So, for you now to nicely understand what is happening, or to know that you want to make a diagnosis of meningitis, before you do even the laboratory investigations that are needed, you have to know the signs and symptoms of meningitis. So the common signs and symptoms of meningitis are these neonates will present with the fever. We know that this fever comes in as a result of the infection that has been introduced in the body. Also, we know that the effect that is there, the brain is involved in here. So these neonates will present with an altered level of consciousness. Also, there will be irritability, or would say that these patients will be lethargic. There will be photophobia. We know that when we talk about photophobia, it means that they do not go along, or they do not correspond with any bright light that is introduced near them. They will also present with vomiting and poor appetite. In 20 to 30% of the cases, they present with seizures. And also, they present with bulging of the fontanelle. More important now in the signs and symptoms of the presentation of meningitis is the stiff neck or the neutral rigidity. Okay? So also there will be what we call as the meningismus, which means there will be the stiff neck. If we do the Brunzinski and the Koenig signs, they will be present. So if you look at the diagrams that are there on the PPT, you will see how nicely we do the Brunzinski sign, where you hold the neck of the head of the baby, then you tilt it a bit. So if you tilt the legs, if there's a presence of meningitis in this baby, what will happen is that the baby will flex the legs up. So you know that that is one of the indicative sign of meningitis. Okay. Also, if you do the Koenig sign, this is where you tilt the leg of this neonate. As you tilt it, sometimes this baby will do what? They tend to feel pain, or sometimes they will raise their head. But above all, for you to make a diagnosis of meningitis, we do what we call as the lumbar puncture. Okay? So during lumbar puncture, what we're interested in is that we are getting the cerebrospinal fluid in between the two vertebrae of the spinal cord. But before you do lumbar puncture, there are certain things that we consider also, or things that are contraindicated. So one of the most contraindicated thing when you want to do lumbar puncture is, if you've noticed that there's an increase in intracranial pressure, we do not do lumbar puncture, because we know that it will bring about the risk of developing hernia, or the risk of herniation. Also, if there is cellulitis, we know that on the area where there is cellulitis, there is already infection. So once we do a lumbar puncture, because there we're pressing a needle, which means this infection, as a result of the nearby cellulitis that is there, it is easily spread. Also, if we know that this infant has a breathing disorder, we do not do a lumbar puncture. Above all, in cases where there is respiratory distress, we do not do lumbar punctures. So it is very important for you before you do a lumbar puncture to know the contraindications of doing a lumbar puncture. So we know that during this lumbar puncture, our interest is the cerebrospinal fluid that we want to look at. So the table there nicely tabulates what the findings are when it's meningitis, because we know that this meningitis sometimes can be bacterial or it can be viral. Okay, so if you look at the figures there, you can see that in the WBC, it's greater than 7 limbs mean, and if you look at the protein in this, it is in the range of what, 5 to 45, and the glucose here are less than 2.5 millimoles. When those are the normal ranges. So it is important for you to understand what the normal for you to find the abnormal. So let us look at in bacterial or acute meningitis. You'll find that the ranges in there now, they'll do what? They will change. Okay? They will go above the what? The normal values. Same applies to the protein levels there. They will change. The levels of glucose now, they'll do what? They'll decrease. Okay? So sometimes if you find that the second part there is still part of the bacterial, and we've seen the levels that have been tabulated. If it is TB meningitis, we look at the values, you know that they'll go above the normal as well. Also, the protein levels will change. The levels of glucose there, they'll do what? They'll increase to 2.5. If it's fungal, the levels there, they'll also be in the ranges of 25 to 500. Protein levels will be in the ranges of 25 to 500 as well. And glucose levels now, you find that they'll be lesser than 2.5. When it's viral, you know that there'll be an increase, they'll be less than 1,000 WBCs. Protein levels will be in the ranges of 50 to 100. But the glucose levels in here now, it will be normal. So if we look at it on the gram stain now, those two, Haemophilus influenza, that is the picture that is there, that's how it looks. So it is important also to have that picture in mind to know the presentation of Haemophilus influenza on the gram stain. So the other picture there is for Streptococcus pneumonia. So that is how it will look like on the gram stain. So let us look at bacterial meningitis. So bacterial meningitis, those that are in the ranges of 3 to 8 months are the ones that are more highly at risk. And the prevalence in most of it, or the 60% of the cases, you'll find that this bacterial meningitis, it will be found in children that are that are less than 5 years old. So in units, you should know the most causative agents of bacterial meningitis in units. So above all, the most common causative agents, you find that it's Klebsiella, Enterobacter, Salmonella, E. coli, also the group B, Streptococcus. But in older infants or children, the most common one is Neisseria meningitis, and Streptococcus pneumonia, tuberculosis, and also H. influenza. So, the most common clinical manifestation of bacterial meningitis are in neonates and older children. These present with fever. We know where the fever is coming from. The generalized body malaise, we know where it is coming from, because we know that, remember when we talked about tetanus in relation to the spasms that are occurring in the body, this is what will bring about the generalized body malaise. Also, there will be vomiting. Sometimes vomiting is induced due to the increased intracranial pressures. We know that the brain manages there, it's the brain that is involved there. You find that there will be alteration in the mental status of these patients. Sometimes they will present with shock, and in other patients they will present with DIC, disseminated intravascular coagulation. Also, there will be a presentation of what? Cerebral edema. But for you to really make a diagnosis of cerebral edema, you look at the vital signs, also on the level of consciousness. So, when there is increased intracranial pressure in these patients with meningitis, for you to really know that there's increased intracranial pressure, there is a triad that we follow, and this is what is called as the Cushing's triad. This is very important and something that you have to know and put on the fingertips. Because in most of the questions that are asked, for you to make a diagnosis, use the Cushing's triad. You'll be asked to say what are the three components of the Cushing's triad. So you know that when there's ICP, which means increased intracranial pressure, we will use them, the Cushing's triad. Above all, the first presentation that will be is that when you look at the eyes of this patient, there will be papilla edema. Also, on the Cushing's triad, there will be signs of bradycardia. There will also be irregular respiration and hypertension. So, if there is a presence of these three things in these patients that we are suspecting meningitis, we also know that there is an increase of intracranial pressure. Okay, so as I said, that you notice this papilledema in the what? In the eyes. So above all, you look at the what? The pupils of the patient. So the treatment for increased intracranial pressure, what you do is that we will give 30% of sodium chloride and 5 cc per kg for 20 minutes. Also, we may utilize osmotherapy if the osmotherapy is greater, is less than 3,000 or 320. Sorry. Also, we may do mild hyperventilation. Okay. So we may also do, typically we give the pressures, we monitor and we keep the pressure, the pascal pressures between 32 to 38 toes. Also, where this patient they are resting, you elevate the bed to 30 degrees. So fluid management in these patients with meningitis. The goal is to restore what? The intravascular volume and to increase the perfusion. But important of all, if we are now giving fluids in meningitis, we have to monitor the serum. Also, we will do this monitor through what? The urine output. Okay? So, if serum sodium is less than 135, you restrict the what? You restrict the fluid intake. Okay, until you stabilize or regularize the what? The sodium, and you ensure that this sodium has done what? Has improved. But if this patient is severely they are in a hyponatremic state, you give 30% of sodium chloride. Okay, so we also give SIADH in the ranges of 4 to 88% if it is bacterial meningitis. But if it is viral meningitis, we give it in the range of 9 to 64%. Okay, also if there is the diabetes insipidus, we also give what? The fluid, and also, but it is important to monitor what the cerebral salt what? Are wasting. So, what is the treatment or the duration of treatment? So, in neonates, we will treat these patients for 14 to 21 days. If it's gram-negative meningitis, we will treat them for 21 days. If it's pneumococcal or influenza, we will treat them for 10 days. If it is just meningococcal meningitis that is present, The treatment duration is 7 days. Bacterial meningitis for neonates who are greater than 3 months, we will start them with the ampicillin. So the ampicillin will cover the Listeria. We will also add the cefotaxime if we know that there are high cerebrospinal fluid levels. And also here, because what you know we're looking at, there is less toxicity than the aminoglycosides. Okay? Also, we will look at ensure that there are no any other drug levels that need to be followed. We also ensure that there is no any is not extracted in the bowel, or it's not being inhibited in the bowel florals. So the complications that may arise as a result of meningitis are hydrocephalus. Also, there will be subdural effusions or empyema in 30% of the cases. We know that there will be presence of spasms that are there, so because of those spasms, these babies or these neonates or other children, they will develop stroke. Also, there may be gyrus sinus thrombophlebitis, and also there can be abscess may come in as another complication. The outcome in neonates is 20% mortality. In other infants and children, there is lesser than 10% mortality. But 30% of all these cases of bacterial meningitis will be neurologic abnormalities by the time that will be discharging them. Some of the 11% of these abnormalities come in at a later age, almost like 5 years later. Okay? So also in others there will be loss of sensorial hearing in 2 to 29% of these infants that are treated with bacterial meningitis. So as we also look at bacterial meningitis in children, you will find that there is streptococcal pneumoniae that is there, that is common, Neisseria meningitidis. Also, there will be TB meningitis, also amphibious influenza. So there, that's a peak of the brain. You can look at it, how it looks like when you do postmortem. So you can take time to Google more pictures so that you can familiarize and see the way it looks like. So we'll talk about meningococcal meningitis now. So most meningococcal meningitis is caused by Neisseria meningitidis. Most of these, in 10 to 15%, comes in as a result of chronic throat carriage. It may come in as an outbreak in dorms or household. It accounts for about 5% of all cases. It peaks in those that are less than 2 years of age, 15 and 15 to 24 years. Okay? So meningococcal meningitis or meningococcal disease, it may bring about purulent conjunctivitis, also septic arthritis. That may be things that may come along with it. On the diagram there, you can see the meningococcal simian patch. So these are patches now that come on the body. On the body. It's one of the early signs and symptoms that can help you make a diagnosis of meningococcal meningitis. So these patients, if you look at them, you'll find that on the skin there are patches that are formed. These patches, they may be black, they'll look black, others will be pinkish. Also, when it worsens, there will be what we call as the meningococemia papilla permanens. So these are the ones that sometimes they'll form like, they'll be white and deep purple, sometimes they'll be reddish on the hands, and more common on the thighs and the legs. So those are the pictures that are there. You can take time to look at them so that you can nicely appreciate the presentation of meningococcal meningitis. So for you to make a diagnosis, we know that we do what? We'll get CCF. You do the CCF gram stain and the culture. You can also do sputum culture. Okay, so you know that we can also do the scraping of the pressure that are formed on the what? On the skin. We can also do the buff coat gram stain. Okay, so the meningococcosemia is capable of transmitting organisms up to 24 hours after initiation of what? Appropriate therapy. So the dopage precautions are within what? 24 hours. After 24 hours, then you cannot do what? Any other isolation. But the incubation period is in between 1 to 10 days. But sometimes it can even be lesser than 4 days, also depending on the what? The immune system of the person. The treatment, the advantage of meningococcemia is that the resistance when you do culture there it's very rare. So antibiotics, we can either give cefotraxone or cefotaxime with a combination of penicillins. Okay? So on discharge, it is important to give what? Rifampicin into these patients that we've treated. So, which will act also like a prophylaxis drug. So, rifampicin acts as the prophylactic drug of choice. Okay? So you find that once it is being given, sometimes you find that these patients may present with soft contact lenses which look like orange. Sometimes there will be tears on the body. Also, when you talk about urination, okay, sometimes there is increased rates of urine output. Okay, so those who are less than 1 month, you may give them 5 milligrams per kg per oral for 12 days. Also, you can give for those that are greater than 1 month, you will give 10 milligrams per kg. The maximum dose should not exceed 600 milligrams. Okay, we can also give those who are less or equal to 12 years cefotraxone 125 milligrams IM, 1 single dose. Those that are greater than 12 years, we can give 250 milligrams intramuscular, 1 dose. We will also add ciprofloxacin as a prophylactic drug. So rifampicin, cefotraxone, and ciprofloxacin, upon discharge, these are the drugs that we do what? We will give as prophylactic drugs to prevent further reinfection of meningococcal meningitis. Okay? 11 to 9% of the survivors, they have what we call as sequelae. These will present with hearing loss, others will present with limb loss, also with a lot of neurological disabilities that come along with them. 10% cases that come in from meningococcal meningitis is that there will be meningococcal sepsis. 1% of mortality, it comes in if it is just meningitis alone. So let us also now look at another type of meningitis, which is pneumococcal meningitis. Which is most common by Streptococcus pneumococcus, okay, which comes with invasive bacterial infection in children that are greater than 12 months old. This comes in with an instance of penicillin, cefotaxime, and cefotraxone resistance. So when we do culture here and sensitivity, you find that all these patients that come in with pneumococcal meningitis, it is because they are resistant to even the prophylactic drug that we give, like penicillin, cefotaxime, and cefotaxime. Okay, so this resistance of late, it has increased to 40% resistance. Okay, so the strains of these penicillins, cephalosporin, and other B-lactam antibiotics, they are also resistant to trimoprin and sulfamethoxazole, erythromycin, and chlorpheniramine and tetracycline. So, the management of pneumococcal meningitis, we know that it is resistant to this other drug. We will give vancomycin with cefotaxime or cefotraxone if this infant is greater than 1 month old. Okay, so if hypertensive allergic to B-lactam antibiotics, we use vancomycin and rifampin alone. Okay, so the only time that we would discontinue vancomycin is when they have shown the acceptance of penicillin susceptibility in these patients. At that time now, we can withdraw vancomycin and continue with penicillins. You also consider adding rifampin if susceptible and conditions are not improving on cefotaxime or cefotaxone. So the only time now that we can now put rifampin in this patient, if we know that there is no susceptibility in this patient after treating with cefotaxime and cefotaxime. So what you should know is that we cannot give vancomycin alone. So the antibiotics that we can use in pneumococcal meningitis, we can give penicillin if it is not resistant and is susceptible to organism. We can give penicillin G. Also, we can give cefotaxone. We can also give cefotaxime. We can also give chlorpheniramine. Okay. So also we do an adequate cephalosporin levels of CSF in between 2.80 hours after the dose administrations of these antibiotics. Let us also look at other antibiotics in pneumococcal meningitis that are resistant. Okay, resistant. We talked about rifampin there, which has a slowly bactericide. We also talk about meropenem, carbapenem, okay, which has an increase of seizure incidences, and this is why we do not usually use it in meningitis. And also, there's been a report of resistance. So also we know that there are certain precautions that are supposed to be that have come up with the CDC recommendations and standards on the infection control precautions. Which means that through recommends that CDC recommends standard precautions through the word airborne, droplet. Also, contacts are not recommended in these patients with pneumococcal meningitis. Also precautions that are not recommended is nasopharyngeal cultures of family members and contact. This is also not accepted. And also we do not allow isolation of contacts. And we do not also give chemoprophylaxis of medication to the close contacts. Remember that here there is inflammation also, so there are also steroids that we use most. We can use dexamethasone in meningitis. We can consider it if there is influenza there, streptococcus pneumonitis, and those that are greater than 6 weeks old. We will give them dexamethasone of 0.6 milligrams per kg per day. Okay. Also, if there's decreased the local synthesis in there, we can also, where we talk about the IL-1, the PAF, the prostaglandins, resulting in the drop of the BBB permeability, and also when there's a decrease in the meningeal irritation there. So also in debatable weight, when there's a decrease in the incidence of hearing loss, if used to be given shortly, it should be given shortly before or at the time of antibiotic administration, because this may adversely affect the penetration of the antibiotics into the cerebrospinal fluid. Let us now look at TB meningitis, which is more common in children in between 6 months to 6 years. You find that there is a local microscopic granulomas on the brain meninges that are found. So this meningitis, what happens is that it may present weeks after the infection has spread or months later, which may be a primary pulmonary process. So if we do a CCF, if we remove the cerebrospinal fluid there, you find that there will be low levels of glucose and high protein levels. Okay? So when you do the CCF there and you find that the glucose levels are low, but the protein levels are high, it is even more indicative of you to know that this is TB meningitis. Okay, so you can also do an acid fasting bacteria. Also, we can do PCR. Let us look at another type of meningitis, which is viral meningitis. Viral meningitis is very seasonal and it becomes more common in summers. So these patients with viral meningitis will present mostly with a severe headache. They also present with vomiting. Some they present with fever. We know that there's a presence of infection. There will be stiff neck. Also, if you look at the CSF, there will be pleocytosis monos. Also, there is no or low protein levels, no or low glucose levels. The causes of viral meningitis, it is predominantly enteroviruses that happen or sometimes during the spring, summer. Oral fecal route, sometimes it's due to the plus or minus may come with the GIT symptoms. Also, once in contact with these, they may present with the meningitic symptoms that will come in between 7 to 10 days after exposure. Okay, they are less common in causes. Sometimes it's HIV, sometimes mumps and lymphocytic choriomeningitis. Other causes of septic meningitis is leptospirea, which is more found in young adults. Also, this comes in during the late summers. So, which means they will present sometimes with conjunctivitis. They also show signs of splenomegaly if you do the abdominal palpation. If you look at the eyes, sometimes they present with jaundice, rash. This may happen due to exposure to sometimes the animal urine. Okay. So they may also be associated with the limb diseases. These come during the spring, with the spring, the late fall. These they will show signs of rash and cranial nerve involvement. So management of viral meningitis is supportive. We can also, what we do is we'll control the fever. We'll also give analgesics to control the pain. We'll also give antibiotics. But once we do the lumbar puncture, these patients will feel better, because most of the times there is no ulceration that is seen. The outcomes, the adverse outcomes that come in infants who are lesser than 1 year is incidence of speech and language delay as they grow. So let us look at meningoencephalitis, the etiology. The etiology most is caused by herpes simplex type 1 and rabies. So there is what you call as the arthropod bone, which consists of the St. Louis encephalitis, the La Crosse encephalitis, Eastern Queen encephalitis, and the Western equine encephalitis. All these different types of inflammations that are occurring in meningoencephalitis, which are types of causes that are there. The signs and symptoms of Web simplex 1 encephalitis is that these patients will present with depressed or low levels of consciousness. Also, when you do a CSF, you find that there is presence of blood in the the cerebrospinal fluid. Also, on CT scan or EEG, there will be a temporal lobe focus that is shown. Also, there will be a positive polymerase chain reaction that is there. So, if it is in these neonates, you find that there will be a cutaneous vesicles. The treatment here, what you do is we give IV, we give IV acyclovir. Then let us look at the Western Nile virus. So the Western Nile virus now, it comes by a bite of an infected mosquito, which has an incubation period of 3 to 14 days. One in infected persons that there are ones that, when we talk about the prevalence, we talk about the epidemiology here. 1 in 150 are infected with encephalitis. 4% of those are lesser than 20 years of age. So these will present with fever, neck stiffness, stupor, coma, sometimes with weakness or paralysis. Treatment mostly is supportive therapy that is given, and the mortality rate there is it's very low. So in summary, what we do is we know that we ensure that we give antibiotics. Even if lumbar puncture hasn't been done, we can start with the antibiotics. Also, we can give vancomycin and cephalosporin until some identification of known cultures have come out. So, but we ensure that you isolate the bacteria within 24 hours. What is important, you monitor the pupils, because we know that sometimes there may be an increased intracranial pressure. You monitor for all the local signs that can be present. You monitor the heart rate, the BP, the respiratory rate. You ensure that there are no seizures. You also monitor the hemodynamics of this patient that you are having. You look at fluid and the electric balance of the of this patient. Thank you so much for paying attention.